So, and then he covered these terms, basic terms, just to make sure everybody knows. Hyperechoic is stuff on ultrasound that appears more white, more bright. Hypoechoic is the opposite. So hypoechoic literally means too few echoes. So that would be something that's a little darker on ultrasound. Something that is anechoic means without echoes. So that's something that's totally black or pure black on ultrasound. Example of that would be in a normal dog looking at the fluid-filled urinary bladder. The urine inside there, ultrasound-wise, shows up totally anechoic or black. Okay. Isoechoic is a relative term, so you would use that term when you would compare two organs at the same depth level that are sitting next to each other, and they appear to have the same shade of gray to them. Then that you could say those two organs are isoechoic relative to each other. And then we talked about, or he probably talked about, the near field and the far field. So anything up near the top end of the ultrasound image would be the near field. Anything down here deeper would be the far field. Okay. As far as talking about abdominal ultrasound, a couple of just statements to begin with. One is, what can ultrasound really do for you? Well, we mentioned it briefly when we talked about radiographs, and we said radiographs are the best imaging modality if you want to look for the size and shape of the abdominal organs, the margins of the abdominal organs, and you want to compare those organs to the other organs in the abdomen as far as relative size. Like we said, the kidney should be 3 times or 3.4 times, 3 to 4 times the length of L2 in a dog. So you have that built-in control. You're comparing the length of a kidney tube. So on the other hand, we said when we talked about radiographs that the radiographs cannot look inside the organ. So I can't tell you anything about the parenchyma within an organ. So if you had a mass inside the liver or spleen, unless that mass was so big it's bulging the capsular surface and distorting the shape of that organ, you will never see it on radiographs. On the other hand, ultrasound is really, really good for looking at the parenchyma of the organs. So if we have a small nodule inside the spleen and it doesn't bulge the capsular surface, and you would not be able to see it on radiographs, most of the time, notice I didn't say all the time, but most of the time you will see that on ultrasound. So the beauty and really the great thing about ultrasound is it's really good at looking for the inside the organ parenchyma, because radiographs really can't do that. Like most imaging things, whether you're talking about radiographs, MRI, CT, ultrasound, nuke med, any of that, it's for the most part very highly sensitive, but very non-specific. And so in a real world, what does that mean? That means with ultrasound, I can see and count, I can tell you that there's 4 hypoechoic appearing nodules, and I could measure them individually, all inside the liver. Okay, I can basically, sensitivity means you can see them and you can describe the hell out of them. Okay, but I still don't know what they are. I still don't know if they're benign, malignant, or whatever. To increase the specificity, and that means tell you exactly what they are, typically we have to get fine needle aspirates or biopsy and look at those cells under a microscope. And, that can usually tell us what they are, keeping in mind that cytology is probably accurate 70 to 80% of the time, and histopathology is probably accurate 95 to 98% of the time. Neither one of them are going to be perfect. Because you have ultrasound and you know how to ultrasound, it will allow you to diagnose more pathology than if you didn't have ultrasound, because you can see inside of the parenchyma of these abdominal organs. The other thing to keep in mind is ultrasound is best for focal or multifocal disease. In other words, if I have those same 4 discrete nodules inside the liver that I can see with ultrasound, that's really easy. I can tell you, and again, they're sensitive to find them, and I can describe the hell out of them, measure them, tell you about their shape, all that kind of stuff. But on the other hand, if I have a disease that affects the entire liver the exact same way throughout the liver, and it causes subtle changes of the overall echogenicity or appearance of the liver, that's going to be harder to see than if it's discrete mass lesions or nodules in the liver. And there are some examples of disease processes that can do that, such as mast cell disease or lymphoma in the organ of the liver or the spleen. Sometimes it affects the entire organ. That organ is diseased, but it looks sonographically pretty normal. So just because you ultrasound the spleen or the liver doesn't necessarily mean that organ is really normal. You can, we kind of hedge when we dictate reports because we have to say what we know is really true. And so we could say sonographically the liver or the spleen looks normal, but that, by putting the word sonographically in front of normal, that that kind of doesn't back us into a corner, because we know full well that there still could be disease in there. It doesn't show up all the time on ultrasound. And the other thing about real world thing about ultrasound is, most clinicians, most veterinarians find it fun to do. It's kind of a extra, outside of the abdomen, non-invasive exploratory. You can get your probe and look all inside the organs and try to find disease processes and things like that. So most people, once they learn how to do ultrasound, it's fun. Now, like any job, after you do it for a long, long time and you've done a billion ultrasounds, the fun kind of goes away from it, because then it's just routine and just another chore to have to do as part of your job. But overall, I think ultrasound still, for most people, is kind of fun to do. What is the opposite of what ultrasound can do for you? Obviously, that would be what can't ultrasound do for you. And the first one I think is really important. Just because you go out and you buy an ultrasound machine and you have it sitting in your practice doesn't make you a better doctor or a better diagnostician. You have to know how to do ultrasounds. You have to learn how to do it. And some practitioners find the learning curve of how to do ultrasounds relatively steep. I don't think it's hard to learn. Ultrasounds, it's just you have to make yourself do them. You have to practice. Practice makes perfect, and it's probably no more truth to it than when you're trying to learn ultrasound. So there's no way in hell that you or anybody else can go to a weekend course, at one of these big meetings, or in, wherever city you go to, a Saturday, Sunday, 2-day course, and you're going to come out and you're going to be an expert in ultrasound and be a good sonographer. The only way to do this and learn ultrasound is put a probe in your hand and a dog or a cat in front of you and practice multiple times. And then finally, you will get it to where you can feel comfortable doing ultrasound. To me, learning ultrasound is a lot like learning to do downhill skiing. Okay. In that when you first start to take your first ski lessons and you're in ski school and you're on top of the mountain and you're cold, and, it's pretty exciting. But on the other hand, you start to do it and you fall on your face. I mean, you slip down, it's no fun. You got snow all down your pants because you fell down, went down the mountain, halfway down the mountain, sliding down the mountain. When you first start doing it, it's frustrating. You think, I'm never going to get it, and it's no fun. On the other hand, one day you'll walk in after doing a bunch of attempts to do ultrasounds and practice, and one day it'll just click, just like snow skiing does. Okay. One day, suddenly, for whatever reason, now you can do it, and then you can just get better at it. Okay. So I find learning ultrasound is kind of the same way. Because ultrasound is not a specific imaging tool, there is no way to look at an organ and an abnormality or a mass lesion somewhere and know for sure, is that benign or malignant? In other words, you cannot make a histologic diagnosis with ultrasound. You still have to stick it. You still have to biopsy. You still have to get cells from it and look at those cells under the microscope to know for sure. And even histopathology, again, like I said, is not 100% definitive. Okay, just because you have ultrasound doesn't mean you will never shoot another radiograph. Okay, we talked about before that radiographs and ultrasound are complementary procedures. You see things on radiographs you will not see on ultrasound, and the vice versa is true. You see things on ultrasound that you do not see on radiographs. It will also not replace common sense things like being a good doctor, doing the right thing, getting a good history, remembering, keeping in mind the signalment of the animal. Physical exams, orthopedic exams, neuro exams, ultrasound will not replace any of that. Okay. And just because I kind of alluded to this last statement before, just because you see a liver and it looks normal sonographically doesn't mean it is. You can still have diffuse disease affecting the entire liver. It affects it just very subtly. And, sonographically, you may not recognize it or be able to pick that up. And just because you have a nodule or a mass in the liver doesn't necessarily mean ultrasound will always demonstrate it. Sometimes those nodules have the same acoustic properties of the surrounding liver or the surrounding spleen. And if it does, you probably won't see it on ultrasound. So again, ultrasound, like any imaging modality, is not perfect. There's going to be some diseases that you just can't see. Okay, scanning tips. Dr. Warner probably reviewed some of this with y'all before. Proper patient preparation, it's hard to say if you say that fast, is essential. And by that, I mean, when you get ready to do an ultrasound, you have to clip the hair on the surface of the animal, that the cavity that you're getting ready to do, and you have to clip it like you're going to go to surgery. So basically, you clip the entire hair where there's no hair left, and you have to do a fairly decent job of it. Okay. If you try to do an ultrasound when the animal has hair on it, even a stubble or something like that, it's going to greatly hinder the image quality that you will see, which again will cause you to make wrong diagnoses and misdiagnoses. Okay. So make sure that in the real world scenario here is you're going to get a breeder person that comes in or a dog show person that comes in, and they're going to say, I think you're going to decide my dog needs to have an ultrasound. I think I palpate a mass. They're going to go, okay, well, we can do the ultrasound as long as you don't clip the hair. And then your answer to that should be, well, if we're going to do the ultrasound, we're going to clip the hair. Because otherwise you're going to do a half-assed job, which not what you should do. Okay. Knobology, the fancy word for you got to know what the knobs do. Okay. So you have to know how to set your machine up properly. So you have to know what's the right gain setting, what's the right depth setting, what's the right time gain compensation setting, all those different knobs and things on the ultrasound machine console. You have to kind of know what they do. In general, there's all kinds of adjustments for ultrasound machines. There's probably at least 100 different adjustments you can make. But in general, once your machine is initially set up, hopefully by somebody that knows what they're doing, then as you do the ultrasound, you'll really only have to fiddle with about 4 or 5 different knobs, but you do have to fiddle with them a lot. Okay. So it's not like x-rays where you can press the button, you get a picture. Ultrasound is moving your hand around and having the probe in the right orientation, and you're going to be constantly adjusting the gain, the depth of the image, and things like that. So it's kind of a very interactive imaging modality. The other thing that I would tell you when you're getting ready to scan the abdomen is you always want to scan the entire cavity, and you want to be systematic in the way you scan it. If you go into the hospital yourself and they ultrasound you, there's a really good chance they're not going to scan your entire abdomen. Human medicine doesn't typically do that. And I think some of that is because of money, and some of that is because of time, and some of it's because we can tell the doctor what's wrong. We can tell them where it hurts. I've been having this clinical sign. Okay, well, we don't have that luxury with animals. And so I think because animals can't tell us what's going on, like what hurts or what the history is, then I think it's probably the right thing to do in almost every case to scan the entire abdomen. So even if clinically you suspect the dog has a cystitis, it's probably not the best medicine or best practice to do to just scan the urinary bladder. We should probably go ahead and scan the remainder of the abdomen, especially if it's an older dog, because you might pick up early neoplasia in the spleen or liver that you didn't even have a clue was there. Okay. And the other thing is, again, you want to be systematic. So you want to learn the right way for you to do ultrasound, and you want to do it that way pretty much every time for the rest of your career. So, for me, when I ultrasound a dog's abdomen, I always start in the region of the urinary bladder. And then I kind of go around counterclockwise around the abdomen. So I start the bladder, I go up the left side of the dog when he's lying on his back, and I look at the spleen and the left kidney and the left adrenal, and then I move up kind of in the middle and the cranial. I look at the liver, the left side of the liver, I swing midline, then I look at the right side of the liver and the gallbladder, then I go down and I look at the right kidney, the right adrenal, and then I kind of look at everything in the middle, like the small bowel and the pancreas, stomach wall, and things like that. That's my pattern that I do when I do ultrasound. That's the way I started doing ultrasounds when I was a resident. And that's the way I continue to do it. And so my recommendation to you is figure out what is your right way to do it, and then get in the habit of doing it that way every time. Apply firm pressure. What does that mean? And that means when you're doing the ultrasound of the abdomen, you want to not be afraid to push down pretty hard on the abdomen. You don't want to just hold your probe with 2 little dainty fingers and barely touch the surface of the skin. Okay. You won't get good imaging that way. You won't be able to see organs that are deeper in the tissues. So don't be afraid to really press down with your probe in the abdomen, and your imaging quality will be better for a lot of reasons. And when in doubt, stick it. And that comes to the fact that, again, this is a non-specific, for the most part, non-specific science, imaging modality. I can't differentiate malignant versus benign disease. I can't tell you definitively what something is, even though I can see it. And so when you have a doubt, put a needle in it, get some cells out of it, and then send those cells off for cytology or cytologic analysis. There's probably only one or two things that I would say probably is a good rule to never stick with ultrasound when you're doing it. And one of them is the adrenal glands. Number one, they're pretty small and they're a hard stick, and they got some big blood vessels around them, so you don't want to miss. And two, the adrenal glands, once you start messing with them, they can excrete a bunch of weird hormones that can have bad effects early, real quickly once you stick them. So most people would say stay away from adrenal glands with a needle. But everything else in the abdomen is pretty much fair game as long as you can safely do it. Okay. So did he talk about artifacts with you? So do you know what posterior enhancement, posterior shadowing, mirror image artifact, all that is?
Yes, sir.
Awesome. So I would review those artifacts. You can use this slideshow to do that, or the ones that he gave you. And I would review the artifacts. Just make sure that you kind of know basically what they are and what could cause them. Okay. So then we're going to start off with the real abdominal ultrasound lecture. We're going to start off kind of do it the way we did abdominal radiology, and we're going to do it by organ system. And so the first one we're going to talk about is hepatobiliary system. So basically liver and gallbladder. First thing, and this is the cool thing. And again, this is always like to say, this is Brian Poteet's. We're going to teach this as easy as possible, give you real world examples, clinically useful stuff that you'll be able to walk out and day one you'll be able to use clinically. This is not a lecture to prove that I'm smarter than you, because I can guarantee you I'm not. I just got there first because I'm older. Probably everyone in the room out there is a lot smarter than me. Okay. And I want to make things, some academicians tend to teach things that they explain things more complex than it really needs to be. I kind of do the opposite. I want to dumbify it down, and I want to make everybody easy, give examples that are easy for everybody to understand. So let's make this as easy as possible radiology ultrasound class. That's kind of the way I kind of think. Okay, so here is from your anatomy book, starting in the liver. You remember the liver has 6 lobes. It has 4 big lobes and it has 2 smaller lobes. And each one of those lobes has a name. And this one is from the cranial aspect, looking down, like cranially down at the liver. From the caudal aspect of the liver, so from the tail looking up, then you can see the different names of the liver lobes. So here's the other small ones, the quadrate lobe and the caudate lobe. Okay. And so we know that the liver, number one, you should know it has 6 lobes, and you should probably know the names of the lobe. But on the other hand, with ultrasound, in a normal dog, when you're scanning the liver, you can't tell where one lobe begins and one lobe ends. They all look the same. So sonographically, in a normal dog, the entire liver looks the same. You can't tell divisions between lobes. They all blend together. And so because of that, you don't need to worry about the names of the lobes of the liver with an ultrasound. You just say, I see a mass on the left side of the liver, midline of the liver, right side of the liver. Okay. That's the easy way to do it, and it works. Okay. The only lobe I would suggest that you kind of keep in mind, and here's the reason why, it's kind of cheating really, but it works, is that remember the caudate lobe of the liver. Okay. It's on the right side of the dog, and it's the lobe that sits right in here. This says renal fossa right here. That's where the right kidney sits. So the right kidney, the cranial pole of the right kidney, sits in this cavitary region of the caudate lobe of the liver. And so the only reason I tell you that is when you're ultrasounding, and if you have an owner, or let's say the owner is an MD, physician, or another veterinarian or whatever, and once you're scanning, if you see the right kidney sitting here, the hunk of liver that sits right cranial to the right kidney is always going to be the caudate lobe. Okay. And so you can be scanning and kind of talking out loud. You can say, oh, the right kidney looks pretty good. Oh, and there's the caudate lobe of the liver right in front of it. It looks pretty good. That may be the only name of the liver lobes you remember, but if you say it, they will assume you know the names of the rest of the lobe. Okay, so it kind of makes you look smart, even though you may not have a clue what the names of the rest of the liver lobes are, but the caudate lobe always caps the right kidney. It's always sitting right top of the right kidney. Okay, that's the only reason. Okay, so what is the normal liver? Should it look like on ultrasound? It kind of has a medium level, moderately rough, homogeneous architecture to it, kind of a salt and pepper appearance to the liver. It is more rough in appearance than the spleen is when we talk about spleen coming up. This is another thing you should know for the test and real life going on. Okay, this is an acronym, and I used to remember it, truthfully not this way, but the way I remember it, I can't say anymore. So slinky, remember the word slinky. So remember S, L, and K in the word slinky. So of those three organs in a normal dog or cat, the spleen should be the brightest, so it's the most echogenic. The liver is a little more hypoechoic than the spleen, and the kidney cortex is usually the darkest of those three organs. Okay, so if you remember them from brightest to least brightest, or from more hyperechoic to hypoechoic, spleen, then liver, then kidney. Okay, you should probably know that for a quiz coming up. Okay, inside the liver, you will see prominent tapering vessels. So you see obvious blood vessels inside the liver, and as they extend to the periphery of the liver, they should taper down nicely. Okay, the margins of the liver are nice, crisp, thin, smooth, white, hyperechoic margins, the capsular surface of the liver. So if I look here, this is a normal section of liver. So right in here, this big organ right in here is all liver. Okay, when we ultrasound, remember, let me back up. When we talked about radiographs, we mentioned this one thing called hanging protocol. Remember that? And that basically is a term that refers to back in the old days when you would hold an x-ray in your hand and you would hang it up on a view box. Which way do you do standard orientation of how you hang it? Okay, and then we talked about in veterinary medicine, you always hang radiographs, lateral view radiographs, with the head to the left. Okay, we typically don't put the head to the right when we hang those x-rays or look at those x-rays on a monitor. So typically it's always head to the left. Okay, well, with abdominal ultrasound, the orientation is the same. Why screw it up? Why make it different, right? And so with ultrasound images of the abdomen, the orientation is always going to be head to the left. So we know the left side of this image, that's cranial, and this is caudal. Okay, because most of the time, especially when you are ultrasounding a dog and you're learning, the easiest position to have a dog in when you're learning ultrasound is have them lying on their back. Okay, some people teach ultrasound with the dogs lying lateral, but it's much harder to learn, and I don't recommend it. I would highly recommend when you're learning ultrasound, and for the most part, when you're doing ultrasounds, put the dog on their back and scan them when they're lying on their back. Okay, so when they're lying on their back, that means the probe is touching the abdominal wall, the ventral aspect of the abdominal wall. So the probe is going to be sitting up in here. This is the near field. Okay, so that makes this ventral up here. The deeper areas in here, that's dorsal because the dog's lying on his back. And always, when we position them this way, heads to the left and tails to the right. Okay, so from now on out, when we learn abdominal ultrasound, that's the orientation. It's the same way that we hang radiographs. Okay. Now you're thinking, well, wait a minute. When we did echoes, we did it the opposite way. Head was to the right. Is that right? When y'all did echoes, head was always cranial to the right. And that's the reason being is when the veterinary cardiologists, which are the ones that do the great majority of the echoes, when they do echoes, when they started learning how to do echoes, they were reading the human literature. In the human literature, faces the head or cranial to the right. And so the veterinary cardiologist got in the habit of imaging it backwards. So heads to the right when you're doing echoes. Any other imaging modality in veterinary medicine heads to the left. Okay, so that's why it's the opposite with echoes. They had to complicate things. So again, let me go back to this slide. So what's the anatomy of everything else around the liver? So we know this is liver, kind of that medium level, salt and pepper echogenicity. Here's some blood vessels in the liver. Okay, this is stomach right in here, and we'll talk in depth more about stomach and stomach wall, but take it for now. That's the stomach. It's got a little gas in it. okay? This area on top of the liver, ventral to the liver up in here, this is skin, subcutaneous fat, and this is probably a little bit of falciform fat in the abdomen, ventral to the liver, okay? And then you have this swooping white line, the smoothly marginated line here. In reality, that is the diaphragmatic margin, okay? So that represents where the diaphragm is. Now realize that when I said that, I hedged. I didn't say that is the diaphragm. That represents where the diaphragm is. Okay. So think about, why would I have said that? Well, what is the diaphragm made out of? It's made out of muscle. It's made out of smooth or skeletal muscle, depending on the species, right? So it's made out of muscle. And muscle is basically water. And so muscle itself will typically show up kind of hypoechoic, kind of like the liver. Okay. So why is the diaphragm hyperechoic? Why does it appear white? And the answer to that is because this white line is really not the diaphragm. Okay. That white line is where the air-filled lung is next to the diaphragm. Ultrasound will not penetrate through air. And so it causes a complete reflection of sound back to the probe. And the diaphragm then appears as a white line, but it's due to air-filled lung right next to it, not really the diaphragm itself. Okay. Okay, so here's another hunk of liver. So here's liver here. This is the dorsal aspect of the liver, kind of deep in the abdomen. Here's liver. This whole big triangular looking thing here is liver. Okay. This up here is probably subcutaneous tissue, as well as a little falciform fat here. Here's part of our diaphragm, this white line over here to the left. This is stomach. So you can actually see rugal folds inside the stomach right in here. Okay. So let me ask you another question. If I have this one slice of liver, and remember that slice is probably a millimeter or 2 millimeters in thickness. So it's one individual slice of the liver. It's like if you go, to the deli at Foster's Food Fair, and they're going to slice up in the deli some lunch meat for you, and you have this big chunk of roast beef, and they slice it for you. If you get one of those slices and you hold it up to the air and you look at it before you eat it, does that, if that slice looks normal to you, does that mean the rest of the hunk of the roast beef is normal? Absolutely not. It's not. And so if I look at this one slice of liver, I can't tell you if the rest of the liver looks just like that or not. So you have to make sure, as you fan through this with ultrasound, that you fan through the entire liver and you see every little crook and cranny and every margin of that liver. Okay. So right in here, I can tell you right in here, there's part of the liver up in here that's cut off. And so you'd have to manipulate your probe and angle it up that way to see the edge of the liver. Make sure you see this part, because again, that could be up in here that's out of the field of view. That could be where the pathology is. So you have to make sure, no matter with ultrasound, no matter what organ it is, that you take the time to fan through the entire organ. You can't just get 2 or 3 slices and assume, well, the rest of it's probably going to look the same. Okay. Okay, so here's another hunk of liver. So we got liver here. This is all liver. Okay, falciform fat, skin up in here. Here's the diaphragmatic margin right down in here. This is stomach wall, these little layers in here. This is gas in the stomach. That's a reverberation or comet tail artifact. And that's due to gas in the stomach because, again, ultrasound doesn't penetrate through gas very well. Okay. So, and then inside the liver, it's kind of, that's got that overall, medium level salt and pepper echogenicity. It's got blood vessels here. It's got a blood vessel here. You can see these linear hyperechoic lines. That's a blood vessel inside the liver. Okay, here we can see these same hyperechoic lines. So that's probably a blood vessel that's coming directly out at you from this slice of liver. Here's another hypoechoic region or anechoic area. That's probably another blood vessel that's coming directly out at you. Here's some end-on or some, oblique views of some vessels. That's probably kind of the same as this, but you don't catch them perfectly. Here's another one down in here. So prominent vessels inside the liver. Oh, okay. This is another example here that you'll see a lot, and a lot of vets will confuse this too, is that, again, here is a cat. Okay, here's an x-ray of this cat. Here's an ultrasound of the cat. I'm looking at the cranial abdomen right in this region here on this ultrasound. So if I look here, this is the diaphragmatic margin. This hunk of stuff here, this kind of hypoechoic area, that's the liver. But in this cat, we have a large amount of falciform fat. This is a fat old cat. Okay. And so this fat you're going to see with ultrasound, and it's all of this tissue, in this case, above or ventral to the liver. So all of this is fat right in here. So it's not unusual in really fat dogs and especially fat cats to see a bunch of falciform fat ventral to or on top of the liver. This is the liver. This is falciform fat. I get, not unusual, I will get ultrasounds that come from other people to read, and they mistake this as a mass in the liver. Okay. And it's not, it's just a fat cat. It's just a bunch of fat. So here it is. And again, with ultrasound, ventrals this way and dorsals this way. With radiographs, we look at them head to the left always, but now radiographs, ventrals this way. And so if you get confused, you can just kind of flip the cat over and now it makes sense. So there's liver here, there's liver down here, here's fat up here, here's fat up here. Okay. So that's how they kind of correlate. So big old fat cat. Okay. Okay, the intrahepatic veins. Now let's talk about them. We said, number one, the veins should be very prominent. They should taper normally. You should see them easily. Well, in general, there are 3 blood supplies to the liver, and you learned that in anatomy. One of those blood supplies are the portal veins, and the portal veins carry nutrient-rich blood into the liver, usually from the intestines and the colon, and they go inside the liver, right in the porta hepatis, right in the middle of the liver. And then once inside the liver, they branch like a tree. So they arborize inside the liver. And those are the vessels that you can see in the liver. They should taper normally as they extend into the periphery of the liver. So portal veins take nutrient-rich blood from the small intestine and a little bit from the colon. They dive into the liver and branch all throughout the liver. Okay. The other blood vessel, another blood vessel type that is you will see inside the liver are hepatic veins. Hepatic veins, they take blood out of the liver. So they take blood, deoxygenated blood, out of the liver and stick it back into systemic circulation. So the portal veins, you'll see them in the liver, but they take blood out of the liver, drain blood out of the liver, and dump it into the cauda vena cava, where then it travels to the heart and gets recirculated. Right? So those 2 portal veins and hepatic veins you will see inside the liver all the time. The other blood supply to the liver are hepatic arteries. Hepatic arteries are very small, and they are the oxygenated blood, being arteries, and they take oxygen and oxygenated blood to the liver so it can stay alive. Sonographically, you will probably never, ever, ever see hepatic arteries. So sonographically, we can play like they're not there. So we know that from anatomy, the liver has 3 blood supplies. Sonographically, you only have to worry about 2 of them, which are hepatic veins and portal veins. And the cool thing is sonographically, typically you can tell the difference by looking at them. And it just so happens that portal veins tend to be the vessels that have white walls. So here's branch of a portal vein here, it's got white walls. Hepatic veins are just black. They don't have white walls. Okay, so by looking at it, if we go back to this picture here, what kind of vessel would this be? Okay, it's got white walls around it. Those would be portal veins. Portal veins have white walls. Okay, this vessel that you see end on here, that's probably a hepatic vein. It doesn't have a white wall. Okay, so you also need, for this coming up test, you need to remember that portal veins have white walls, hepatic veins don't. Okay, so again, if I put a picture like this on a test and said, what vessel is that inside the liver? Here's liver, there's a vessel inside of it. Your answer would be, it's a portal vein. Why? Because it has white walls. Okay, vessels outside of the liver, we kind of reviewed that already. We don't really need to do it again. So the portal vein, again, is the vein that comes, the main vein that comes from the abdomen itself, and it takes blood that has come from the small bowel and a little bit from the colon, and it goes cranially towards the liver, enters into the middle of the liver, and then once inside the liver, those vessels branch inside the liver and they have white walls. Okay. The cauda vena cava is another big vessel in the abdominal cavity. It's located more dorsal, so right along the spine in general. And the cauda vena cava never goes into the liver. Okay, the cauda vena cava dives dorsal to the liver and goes right next to the liver dorsally but never enters into the liver. So if you see a prominent vessel inside the mid-abdomen and it's in the mid-abdomen and you trace it cranially and it goes directly into the liver, you can bet that's probably the portal vein. Okay. If you see another prominent vein inside the abdominal cavity and you trace it cranially and it never goes to the liver, it goes kind of dorsal to the liver, but never enters the liver, that's probably the caudal vena cava. Okay, so let's see. I'm going to get past a couple of pictures here. That's a really crappy picture. I need to put another one in. Okay, so let's talk about some disease processes that can affect the vessels inside the liver. Probably one of the more common ones you're going to see is congestion of the liver. So this is usually due to right heart failure. So these are where blood goes through the caudal vena cava, and normally that blood should enter up cranially into the right side of the heart, okay, where then it goes from the right side of the heart to the lungs, gets reoxygenated, it goes back to the left side of the heart, and then gets pumped out through the aorta, right? Well, if you have an animal that has right heart failure from whatever cause, okay, so the right heart is having difficulties, it's having issues, and it can't accept any more blood because it's already full of blood because it can't get rid of it. Okay, that will lead to, it's like plumbing, that will lead to blood backing up into the caudal vena cava. And so if blood backs up into the caudal vena cava because the right heart's not working well, then everything that enters into the caudal vena cava will have stagnant blood flow and will tend to back up. Okay. Well, we just said that one of the vessels inside the liver is the hepatic vein. The hepatic veins take blood out of the liver and normally dump that blood into the caudal vena cava. Okay. Well, if the plumbing's backed up, then the hepatic veins can't dump their blood content into the cava, and they sit in the liver and they become dilated and get too big because they can't get rid of their blood supply. So passive congestion is where you have dilated hepatic veins. Those are the vessels inside the liver without white walls. Okay. So anytime you see dilated intrahepatic veins or a dilated cava, that should tell you one thing, that most of the time you need to go look at the heart. Okay. There's something wrong with the heart that's causing blood to back up into the caudal vena cava and subsequently into the hepatic veins. So that could be due to right heart failure, due to tricuspid valve disease. It could be due to pericardial disease. It could be due to a mass in the right side of the heart. For whatever reason, the right heart isn't working well, and it leads to passive congestion of the intrahepatic veins. Okay. Another disease that happens with veins and vessels inside the liver are portosystemic shunts. And you will learn more in detail about portosystemic shunts coming up in your next lectures in internal medicine, and probably surgery. We'll touch on it too. But let's just talk about them very briefly, in that the easy way for me to understand portosystemic shunts is, again, you can have basically two kinds of portosystemic shunts. Well, first off, let's define what is a shunt vessel. So a shunt blood vessel is an abnormal blood vessel that connects something to something else, but is abnormal, and usually it's shunting blood or rerouting blood to a wrong place. Okay. A portosystemic shunt is it's an abnormal blood vessel that connects the portal system to the systemic circulation. So basically, it's a blood vessel that connects part of the portal vein or branch of the portal vein to the caudal vena cava, and the blood then is not allowed to normally go into the liver like it should. Okay, so it bypasses the liver. Okay, there are two basic kinds of portosystemic shunts. There's ones that are actually in the liver itself, and then there are other ones that are outside of the liver, right next to the liver. Okay. So in general, intrahepatic portosystemic shunts are unusual. Okay. They're pretty rare, and they almost always happen in large breed dogs, and they're congenital. Okay. Sonographically, they're not hard to find because you look for usually a dilated kind of tortuous vessel that directly connects one of the intrahepatic portal veins to the caudal vena cava. So you look for a direct connection with ultrasound, usually an abnormal little tortuous vessel that connects a portal vein to the cava. And again, almost always they will be congenital. The animal's born with it. and they're almost always large breed dogs. The other kind and more common type of portosystemic shunt is going to be an extrahepatic shunt, meaning outside of the liver. Okay. And we can further subdivide extrahepatic shunts into two different kinds. There's some that are caused by only a single vessel shunt, and there's some that are caused by multi-vessel shunts. Okay. Of those two subclassifications, by far the most common is a single vessel shunt. So this is an abnormal blood vessel that connects sometimes the portal vein inside the abdomen, not in the liver, but inside the abdomen to the caudal vena cava, or the portal vein to the azygos vein, or the portal vein to a renal vein, something outside of the liver, an extrahepatic shunt, but it's only one little abnormal blood vessel. Okay. Those are the kind that by far are the most common. They're also almost always congenital, but they almost always happen in little bitty breed dogs, so little toy-like dogs. They can happen in a cat and they can happen in a larger breed dog, but 95% of them are going to be in little Malteses and little poodles and things like that. So the most common type of portosystemic shunt you're going to diagnose in veterinary medicine by far is a single vessel extrahepatic portosystemic shunt. The other kind of extrahepatic shunt is a multi-vessel shunt. Okay, these are by far most common in people, and these are usually due to chronic liver disease, where now the portal vein, there's more resistance to blood flow into the liver because the liver is diseased, and so then blood again backs up like plumbing would behind the liver, and you form over time these extrahepatic multi-vessel shunt vessels. Okay, they're pretty rare in animals. Every now and then you'll see one, but they're really, really rare. Okay, and so the good news is there really no, or the bad news, there's no cure for a multi-vessel shunt. A single vessel shunt, which is the kind that is most common, most of those animals can be fixed surgically. Okay, so let's look at a couple of pictures. So here's part of the liver up in here. Here's the caudal vena cava. And again, the caudal vena cava comes from the caudal abdomen. It never goes into the liver. It kind of dies below the liver here. And if you could follow it cranially, it would go into the right side of the heart. Okay. And here's a big dilated branch coming off the caudal vena cava into the liver. And you look at it, and does that vessel have white walls? You go, no, it doesn't have white walls. So it must be a hepatic vein. And it's big and dilated. You can kind of think of it like this. Here's the caudal vena cava. That's a big, major vessel. Okay. And the caudal vena cava is, the analogy would be, it's the trunk of the tree. So it's big and, big and dilated here. It's the trunk of the tree. And this is a branch coming off the trunk. Okay. Well, this tree branch, in most trees, the branches shouldn't be bigger and wider and thicker than the trunk of the tree. Okay. And in this case, this hepatic vein is as wide, if not wider, than the diameter of the caudal vena cava. So in this example, the branch, if you will, the hepatic vein going inside the liver is bigger and wider than the trunk of the tree. That's not normal. And so that should tell you I have dilated intrahepatic veins, and I should make sure if I see that, I want to go look at the heart. Because usually there's something going wrong with the right side of the heart, because all of the plumbing, again, coming from the right side of the heart, and the caudal vena cava going into that is dilated because the blood can't exit the liver. It gets backed up here because there's something wrong on the right side of the heart. Okay, and this is not a sexist thing, although nowadays I should probably take this slide out, but in the human and medical veterinary literature, there is a sign that people can look for. If you turn your probe 90 degrees in animals that have dilated intrahepatic veins, this is an end-on view of the caudal vena cava, and these dilated vessels going into the liver are dilated hepatic veins. And somebody back in the day said this looks like the Playboy bunny sign. And so this looks like the head of the bunny, and these are the ears coming off the bunny. And so it's easy, it's kind of fun to kind of look for if you suspect hepatic dilatation or hepatic venous congestion inside the liver. You can turn your probe 90 degrees and try to see if you can find the Playboy bunny sign, which has been reported to be a sign of intrahepatic congestion. Okay, so there we go. And if you, again, this is a picture of, this is an echocardiogram, so you should go look at the heart. And this dog had a bunch of fluid around the heart in the pericardial space that puts pressure on the right side of the heart and squishes the right heart. So now nothing can get into the right heart, which again, that in turn backs up the plumbing in the cauda vena cava trying to get into the right heart. Okay, benign hepatic pathology, moving on still in the liver. So we will start this right after our break. How's that? So we got 10 minutes, come back at about 11 o'clock your time. And we will start going through some of these disease conditions in the liver, what you have to look for. All right, I will see you in about 10 minutes.